All right, here we are again. Another presentation of Jason's Handy Dandy CE. I've asked for anyone to send me some patient that they've seen recently to do like a case study. No one's done it, so I'm going to just pick one. This is a patient that I saw in urgent care clinic. Most of the time, the stuff that we get is sutures, staples, orthopedic injuries, runny nose, sore throat, general stuff like that. But occasionally we get something in a little more interesting. So a lady comes in, she says she's a 68-year-old female. She says she's walking her dog pulls her down, she landed on her butt, and now she's having back pain and arm pain. So I go in and assess her, we do some x-rays. She's tender around her lumbar area, mid-spine, tender on her right arm, I believe. Nothing obvious, no numbness or tingling in her extremities. She's able to walk in, no weakness. So we get her x-rays done, and she has a compression fracture in her spine of L2 and a radius fracture. So obviously that's a little more than what we handle here in urgent care, so we sent her on to the emergency department. So again, that's one of those, it's probably fine. How bad can you get hurt from a dog pulling you down and landing on your butt? So these are things that we make sure that you take seriously. So today we're going to talk about stroke. This is going to complement what Dr. Hoffman already talked about, and here we go. All right, so let's talk about stroke. Two types of stroke: ischemic. An ischemic stroke happens when blood flow through the artery that supplies oxygen-rich blood to the brain becomes blocked, and then hemorrhagic is when you have a rupture in one of the vessels and the blood leaks out and puts too much pressure on the brain. Most of the time we're going to be dealing with an ischemic stroke, 87% of the time. So here are some risk factors. Hypertension, number one risk factor. High cholesterol, heart disease, diabetes, obesity, alcohol, tobacco, female sex, and then some races: Black, Hispanics, American Indians, and Alaska Natives. Some of this sound familiar from metabolic syndrome. Impact, got to have statistics. Fifth leading cause of death. There was 133,000 deaths in the United States in 2014. 1 in 20 deaths in the United States is caused by a stroke, and the cost was about $33 billion in 2011. So here, this comes straight from the protocol book. Patients with stroke are going to have a variety of symptoms. Here we have a list of some of the common ones that we should look for. And remember, sudden onset. If this has been going on for 2 weeks, probably not a stroke. If it started 5 minutes ago when it was sudden, this is why we talk about assessment. What were you doing when it started? Did it come on suddenly, or has it been progressively over the last several days? Last known normal, very important. This is really something that we really need to ask these patients. If we're going down the stroke pathway, last known normal is going to be one of the most important things, if not the most important thing, that we need to ask the patient or the family. This is something that we definitely need to relay to the hospital, because in order for the patient to get TPA, this needs to be within 4.5 hours. Remember, it used to be 3. And then for interventional clot retrieval at the comprehensive stroke centers, it needs to be within 6 hours. So the assessment that we need to do is the Cincinnati Pre-Hospital Stroke Scale. It has 3 components: facial droop, arm drift, and speech. This is not new. This is something that we've been doing for a long time, but I think it's a good idea to review it. For facial droop, we want to have them say, "Show me your teeth." Have the patient show their teeth. If you say smile, that's sometimes means different things to different people. If you say, "Show me your teeth," and you're getting them to use all of those facial muscles. Have the person, for arm drift, have the person close their eyes and hold their arms out straight in front for about 10 seconds. If they can't hold up one arm, or if they hold it up and it starts to drift, that's a positive finding. And then speech, have the patients repeat after you. You can't teach an old dog new tricks. Another thing that we need to talk about is when you're assessing a patient's mental status, awake, alert, and oriented times 4. Person, place, time, and event. For person, what's your name? Place, where are you? Time, what year is it? Event, what happened? In none of the stuff that I have read, and I looked high and low, have I found anything about asking the patient who is the president. I'm not sure where that came from. It may be something that was started and has stuck around. I honestly have, I promise you, I've looked high and low to see if I could find some kind of document or some article or something that would have any backing for that, and I have found none, and I got tired of looking. If you can find something that's credible, please send it to me. I would love to know. But again, asking the person who the president is, it definitely doesn't hurt anything, but it doesn't help anything either. It's not a mental status evaluation tool. The Cincinnati Pre-Hospital Stroke Scale, and Dr. Hoffman talked about this as well when he spoke with us about strokes the other day. This has a high sensitivity and specificity. If you'll remember, I talked about this briefly last month, and sensitivity and specificity is how good or how bad a test is. A very easy example would be when we do a strep test in the clinic. A rapid strep test takes 5 minutes to get results. It has a high sensitivity and a high specificity. Sensitivity means if the test is positive, the patient has strep. If the test is negative, the patient doesn't have strep. Same thing, this Cincinnati Pre-Hospital Stroke Scale has been tested over and over and over. I gave you an example there of 2 studies, one in 2015 and one in 2009, where they took patients, if they had a positive Cincinnati Pre-Hospital Stroke Scale, then their admitting diagnosis in the hospital was stroke. So these things have been proven. We know it works. They're easy. And now we've got the other tool that helps us go to a comprehensive stroke center. I think all of that put together is really helping us to identify which patients are likely having a stroke. So the goals of treatment, the first one would be to do the stroke scale. The second one, make sure that we do a blood sugar. We want to make sure that we don't take in a stroke or activate a stroke, code stroke, for a patient with low blood sugar. And always look at other etiologies. Let's look at big picture. You know, I think most of you know this about me, but I'm a big picture kind of guy. Let's make sure that we're not missing something. Are there other causes for this patient's mental status change? Another thing that I would really caution you, when patients call in, they call 911 and they say the patient's having a stroke. Well, they don't know. They're basing this off of Facebook or their neighbor or something that's not credible. So I would really caution you on how much you put into the call information that comes up on the MDC. It seems like I've seen it happen several times where the patient, there's something that the patient is whatever, altered, and the patient or the person, the caller, says they're having a stroke. Well, it seems like sometimes if we see that on the screen, then that's what we focus in on. We need to make sure that we don't get tunnel vision. We need to make sure that we're assessing these patients when we talk to them, say, hey, what's going on today? What happened? What are your symptoms? When did it start? Don't chase something that's not there because someone else mentioned it. Blood pressure. This is something that we're going to talk about in depth. If the patient's MAP is greater than 150, then give them 10 milligrams of labetalol. We can repeat that once in 10 minutes if their MAP is still above 150. 65 to 130 is where we want to keep it, but that 130 to 150 range is a kind of a vague area, and that's really what I want to focus in on today. If we do have to intubate the patient, keep their end-tidal CO2 between 35 and 40, elevate the patient's head. So, like I said, let's talk about blood pressure. I want to make sure that everyone understands I am not giving my opinions on this. I searched high and low and found tons of information that backs up what I'm about to present. If I give you an opinion, I will definitely let you know. So let's dive into this. In patients with ischemic stroke, the perfusion pressure distal to the obstructed vessel is low, and the distal vessels are dilated. Because of impaired cerebral autoregulation, blood flow in these dilated vessels is thought to be dependent upon systemic blood pressure. So what does that say in a nutshell? The increase in blood pressure when a patient has a stroke is to perfuse the brain. Let's look at the second one there. The arterial blood pressure is usually elevated in patients with an acute stroke. This may be due to chronic hypertension, an acute sympathetic response, or other stroke-mediated mechanisms. In many cases, however, the acutely elevated blood pressure is necessary to maintain brain perfusion in borderline ischemic areas. Again, the increase in blood pressure is expected. That is a protective mechanism to perfuse the areas of the brain distal to the clot. And you'll notice here, I don't know if I am the only one that picks up on this kind of thing, or maybe I overanalyze, but this came from an evidence-based article. That means it's peer-reviewed and it's accepted in the medical community. It says this may be. So I'm going to highlight that. Maybe. Oh, I lost my cursor. There it is. May. So that means they're not sure. Here is what we do know. The only thing in all of the information that I looked through, and I looked at the 2018 stroke guidelines, I looked at tons of other resources that are all peer-reviewed, and by peer-reviewed, again, that just means it's accepted in the medical community. An example would be, let's say some patient walks in, I treat them for sinus infection, and they walk out the front door and they drop dead. They're going to look at the guidelines in which I treated this patient. They'll say, okay, well, you did this and this and this and this. These are all accepted. They come from peer-reviewed information or resources. You're good. You didn't do anything wrong. If I was to treat someone outside of those, then it would open myself up that I'm not treating that patient appropriately. So this top bullet here, this is what we know. For the patient to get thrombolytic TPA while they're in the hospital, while they're in the emergency department, their blood pressure should be less than 185 over 110. That's the only hard and fast blood pressure reading that I found in any of the guidelines. I think after, for 24 hours or 48 hours or something like that, after the patient has received TPA, they maintain the blood pressure at 185, less than 185 over 105 or 100 or something like that. So that's the hard and fast. That's all that I found. For patients with ischemic stroke who are not treated with thrombolytic therapy, that means they're not candidates for TPA, we suggest treating high blood pressure only if the hypertension is extreme. Blood pressure greater than 220 systolic or greater than 120 diastolic. Or if the patient has another clear, the key being clear indication, active ischemic coronary disease, heart failure, aortic dissection, hypertensive encephalopathy, or preeclampsia, eclampsia. And then remember here, this grade C, I talked about this last month. That means this is the level of evidence, and this is how it's backed up or not backed up or supported or not supported. So this is a pretty high grade of evidence. When treatment is indicated, we suggest cautious lowering of blood pressure by approximately 15% during the first 24 hours after stroke onset. And I highlighted that, and I wanted to put a huge emphasis on 24 hours. So from the time it happened to 24 hours after is when we want to cautiously lower blood pressure. Now, to me, here is my opinion. Cautious lowering of blood pressure by 15% should not be done by paramedics. That is my opinion. This is something that needs to be done in the hospital. This is something that needs to be controlled on a drip, and it needs to be brought down. If you give a patient a dose of labetalol, it's going to wear off in a few minutes. Are you really doing this patient any good? What is our goal? And I think this is where we really need to focus and really need to think. Again, I'm a big picture kind of guy. Is our goal to lower someone's blood pressure, to take away the protective mechanism that their body is using to perfuse their brain? Is that something that we should do? Is that our goal? I don't think it is. Our goal is early recognition, early notification, early intervention. And our end goal, us in the hospital, the patient to be discharged from the hospital neurologically intact. That's the big picture. That's the goal in stroke care. What are we doing if we're lowering someone's blood pressure if they're borderline? Obviously, the protocol says if their MAP is greater than 150, treat them. But if it's borderline and their MAP is 140, you're not doing them any good by treating their blood pressure. You could be doing this patient harm. And again, this is not my opinion. This is backed by the medical literature. If they don't need it, don't give it to them. That's the bottom line, and that's really what I wanted to focus on with stroke management. Here are all the references. Again, I always use peer-reviewed references. If you would like copies of any of this, please let me know. I'm more than happy to get them to you. Please, someone send me a case study that they want me to go over.